Welcome everybody. So it's my pleasure to moderate this webinar on Pocus on point of care ultrasound. We have two experts with Adrian Wong from Guildford Hospital and with Ashley Miller from Shrewsbury and Telford Hospital. So first of all, I want to thank General Electric Healthcare for supporting this webinar. And an important thing, be free to ask a question on the website. And so this short introduction to start as quick as possible with Ashley. Ashley, so can you tell us what is Pocus?
Jacques, thank you very much. It's a real pleasure to be here for both Adrian and I to be able to talk to you about something that we both love, which is point of care ultrasound. We would like this session to be as interactive as possible, so as Jacques said, please do send in your questions and we'll do our best to answer them as we go along. So just a bit of an outline for you of what we're going to do today. We're going to think about what Pocus is, why we do it, how we put together the different modalities and organ systems. We're going to touch on some training issues, and then we're going to finish up by thinking a little bit about where point of care ultrasound might take us in the future. Now, I think we're all familiar with the familiar model in medicine of when we first see a patient, doing our evaluation by taking a history, performing a physical examination, then we're going to go on and order some tests, maybe order some imaging. And the beauty of ultrasound is that we can use these machines at the very beginning evaluative phase. So instead of the stethoscope, we can use our ultrasound probe, we can look at the heart, we can look at the lungs, we can look at various organ systems to help us make a diagnosis. And not only that, but we can use it to guide treatment. And because we have a machine there all the time by the patient, we can use it to monitor that treatment as well and continually reassess very quickly and easily. So we're faced with a patient as a whole body full of different organ systems, and with ultrasound we can look at the heart, we can look at the lungs, we can look at the abdomen, we can look at the vessels, whether that's for sighting lines, for assessing for venous thrombosis, for looking at venous congestion, for example. And not only can we look at these organ systems as individual systems, but we can integrate them all together because they often affect one another. So we thought we'd just start by having a little look at echocardiography and what that might mean as part of this basic evaluation of an unwell patient. So the basic echo exam that we can do very quickly usually involves four essential views. So at the top left of your screen here, you'll see a parasternal long axis view. We can see the right ventricular outflow tract, the base of the left ventricle, the left atrium, the ascending aorta, the mitral and aortic valves. And we can see nicely from this view whether the chambers are dilated or not. We can look for the walls of the ventricles thickening and systole, moving towards each other. We can rotate our probe 90 degrees to look at the parasternal short axis view on the top right of your screen, where we're seeing the left ventricle in cross section and the right ventricle wrapping around it. Again, that's a nice view for looking at ventricular size and function, a good view for looking at regional wall motion abnormalities. And at the bottom left of the screen, we have the apical four-chamber view where we can see all four chambers of the heart. And then at the bottom right, we have the subcostal view. Again, we can see all four chambers of the heart, but this time looking at it from a different angle. And for a basic echo, we're really just asking some simple binary yes-no questions, all of which can be answered very easily from looking at those images. So we're not doing any quantitative measurements, we're not using any complicated modalities like Doppler, we're just asking some basic questions. So are the ventricles significantly dilated or significantly impaired? Is there any pericardial fluid around the heart which might be causing tamponade? Is there profound hypovolemia? And can we see any pleural fluid? And Adrian now is going to talk to us a bit about a basic lung exam.
Okay. Lung ultrasonography is probably the newest of the various different modalities that we've learned to examine using ultrasound. It was not that long ago where this was thought to be impossible and a waste of time. Just to orientate people in terms of what a normal lung ultrasound looks like, it can be quite boring. A normal lung doesn't look terribly impressive. This is a cross-sectional area where we've placed a probe across the rib, so you could see the rib shadows in between, sandwiching the lung in the middle. You can see the shining, shimmering, sliding of the pleura near the top. You can see the reverberation artifacts, which are horizontal artifacts called A-lines. There. You've got horizontal lines, but you've also got vertical lines. You can see the left-hand side of the picture shining, shimmering there, and I've outlined it there, and those are called B-lines. That's the normal profile of the lung. You've got two lungs, and you can examine your the lungs in a structured, systematic way and construct a diagram, an image of this three-dimensional organ, and you can have an idea in terms of what's happening in each segment of the lung. Using that, and this we can use into a protocol called the basic lung ultrasound examination and ultrasound developed by Lichtenstein and colleagues. The important thing I want you to take away from this slide here is the fact that the sort of diagnosis that you can make: pneumonia, interstitial syndrome, pneumonia again, pneumothorax, asthma, COPD, just by profiling the various different segments of the lungs. And in the trained practitioner's hand, it has a 90% diagnostic accuracy for patient respiratory distress. Just to show you a couple of abnormalities, you're allowed 2 B lines per rib space, and as you can see here, this is a lung image that shows multiple B lines. Here is another picture showing a lung with lots and lots of B lines, which could make you think of a diagnosis such as pulmonary edema, so on and so forth. This is what consolidated lung looks like. Very, very impressive. It's a dynamic scan, so the patient is breathing rather than a snapshot of a plain chest radiograph. You can see fluid and air bronchograms within this examination slide here. Moving on to the abdomen then, the variety of scans that you can perform using ultrasound in the abdomen is obviously very extensive, but for focus scans, what we're trying to pick out and make diagnosis on is just what's the normal appearance of bowel, liver, spleen and kidney, and the presence of free fluid within the abdomen, i.e. ascites, or it could be blood in the context of trauma. This is an image of a patient with quite marked ascites. That's the black anechogenic space right at the top of the screen. This is a picture of a patient with gross hydronephrosis, where the calyces are very, very dilated, and they appear anechogenic as well. Very obvious, very easy to pick out. With regard to vascular side, as Ashley has already mentioned, we use it on a day-to-day basis to insert intravenous catheters, whether you use it in the short axis outer plane view, such as shown in the top left side of your screen, or on the in-plane long axis view in the bottom right of the screen. Both have got their advantages and disadvantages. I think the true power of all the different modalities that we've mentioned already is the fact that you can put it all together. Our patients are not just the heart, the lungs, the kidneys in separate organ compartment system. So you're able to build a complete holistic picture of what's happening to our patient so that you can devise a management strategy and treatment plan accordingly. This is not a new concept at all. One of the earliest forms of putting all of these together is the FAST or extended FAST scan, which is the use of focused abdominal sonography in the context of trauma. You're looking for free fluid, you're looking for pneumothoraces, you're looking at whether there's a pericardial effusion, so on and so forth. A different protocol is the one shown on the screen now, which is the RUSH exam. RUSH stands for the Rapid Ultrasound in Shock protocol, where we classify and look at the circulation with regard to pump, tanks, and pipes, and therefore we can characterize the classical categories of shock into hypovolemic, cardiogenic, obstructive, and distributive, according to what the pump, tank, and pipes looks like. And just for the sake of completeness, there are other protocols out there, such as this one by Professor Lichtenstein and colleagues, called a Sesame protocol for evaluating someone who's suffered a cardiac arrest.
So thank you. First, clearly, it seems that you can assess your treatment by using echography. So do you think that even if, because you talk about non-qualitative measurement, do you think that only with by only the view that we can get, you can assess the treatment for your patient?
Yeah, sure. I mean, from a basic exam, it takes a relatively few number of scans when you're learning to be able to recognise if a ventricle is severely dilated or severely impaired. We're not trying to quantify an ejection fraction here. We're just asking ourselves the question, is this ventricle vaguely normal or is it very, very abnormal? And just being able to answer simple questions like that makes a big difference to how we treat our patients.
And with training, is it easy to get images very quickly?
Depends what you mean by very quickly. You can certainly go on a day-long course and be taught how to obtain all the windows, and then you would go away from there and would be able to obtain all those windows. Certainly in a straightforward patient, it requires more practice on top of that to get all the views on more challenging patients. But yes, a day-long course will certainly put you on your way to learning how to do it.
I think as a trainer, I sort of divide the training process and pathways into separate compartments: image acquisition, image interpretation, and integrating into clinical practice. And we're going to talk about training in the next section of this webinar. But in my opinion, image acquisition, image interpretation is relatively easy. There are courses out there, there are supervisions, training processes out there that will aid that bit of the learning. However, interpreting all of these things, putting it together into a management clinical scenario is what's the most difficult bit, I think. And that requires the learning and mentorship from an expert to guide you, because this is just one bit of trying to define the treatment strategy for a complex patient.
So Adrian, we show us how we can obtain with the lung ultrasound. It's very impressive, and you with a very nice algorithm. So at the end, do you think that when you are good at echo, it could replace the classical lung radiology?
I think it depends on what questions you're asking for and who's actually performed the scan. So I've shown you how easy it is. However, if you've not got the training, you've not got the machine, then it becomes irrelevant in a way. Once we know from studies and in the literature that the sensitivity, specificity of making diagnoses such as pneumonia, pleural effusions, etc., using lung ultrasound is far superior compared to the plain chest radiographs. The caveat to all these studies is the fact that they are done by trained practitioners, and that's the difference, I think.
So some question from the audience. So do you think Pocus at basic level should be mandatory for training intensivists?
We are obviously going to be biased around the people in this room because we're all Pocus practitioners. So my intellectual bias is that I genuinely believe that in order to look after the sick patient properly, you are going to need some basic understanding and the ability to perform some form of critical care ultrasonography.
Yeah, I think I think Adrian and I would both say when our training very first started out, ultrasound wasn't part of normal intensive care medicine. And as that's been changing over time, it's completely transformed my own practice. And I would 100% agree with the statement that it should be mandatory for anyone practicing intensive care medicine, just because it's so useful.
Yes. So what is the best view, it's a specific question, to assess the left ventricular filling, and what about the inferior vena cava diameters? It's a very focused question.
Yeah, the best view to...
The best view to assess left ventricular filling.
Okay, so I don't think you should ever limit yourself to one view. You need to get as many views as possible, and you have to integrate them together to get an idea in your mind about what the ventricle is doing. You can get two views which seem to disagree a bit, and you have to average them out in your mind, or ask yourself what's wrong with one of your images and what you need to change. It also depends on what view you can get.
Yes.
It can be difficult in ventilated patients to get all the views that you need. So it might be that you can only get one or two when you have to cope with whatever you can.
No, I think it's a very important point, is that it's not only one view.
Correct.
It's you have to deal with several views, and so it's make you more accurate.
Correct.
Yeah.
So
IVC, that's a bit controversial. In my own practice, I don't find looking at the IVC very useful. What do you think, Adrian?
So again, I do assess the IVCs, but it's usually as an extra bit of information to put together for the rest of the patient. So if I was worried about a volume status of a patient, I would scan the heart, obviously get whatever view I can, but I also scan the lungs, scan the kidneys, and so on and so forth, to get an idea in terms of volume status. I don't think interpreting volume status just on a collapsing IVC alone is probably prudent. You need more information, and we've hopefully highlighted the power of integrating all of these modalities.
And there's lots of caveats to the IVC.
Correct,
as well, isn't there? In a spontaneously breathing patient, I don't think the evidence is there to support assessment of fluid responsiveness. You have to be ventilated.
So Adrian, maybe you talk about the training and...
Yeah, okay. So we're going to move to training bit, and Ashley's actually going to kick off this bit first.
Yeah, so when you're thinking about ultrasound training, different levels of training have been described. Shown here on the slide in this pyramid. At the bottom you've got your most basic kind of ultrasound exam. At the top, the most specialist level of ultrasound. And when we're talking about basic exams, we're really talking about sort of that emergency bit and level 1, and then comprehensive scanning would be level 2, and level 3 person would be something like a imaging cardiologist. So when we come into ultrasounding critically ill patients, we're coming down at that bottom level there. But as we've shown, that can still be very useful. And there's this slide here just to illustrate some of the differences between some of these terms. So the basic scans, like I talked about earlier, asks very simple binary yes/no questions to identify the most common pathologies that you need to do something about quickly. Comprehensive scanning, a full comprehensive scan with a report, could take anything from 45 minutes to an hour. You're going to go through all the views, you're going to go through a minimum data set, you're going to be interrogating every bit that you can do. Requires a lot more knowledge and experience, requires significant time to perform. I think it's important here as well to differentiate between focused scanning and basic scanning. So the two don't mean the same thing. So you can do a focus scan at quite an advanced level, but you can still do it quickly and just focus it on something that you're particularly interested in. And I've got a case to illustrate that. So this was an echo I did in the anaesthetic room. I got called by one of my colleagues to come and look at a patient who had become very unwell after induction of anaesthesia, profoundly hypotensive, hypoxic. They'd been started on large doses of vasopressors, and they weren't doing well at all. I wheeled the ultrasound machine in, and this is an apical four-chamber view, and I just could notice at the bottom of the screen, it's not the best picture in the world because it's real life, but if you can see the interatrial septum at the bottom of the screen, you can see in some of the picture how it's bowing from the right to the left side, showing both that there's higher pressure in the right atrium than the left atrium, and also there's what looks like an atrial septal aneurysm, which made me start wondering if there could be a shunt there. You can see this more clearly on the subcostal view. It's the right atrium at the top, it's the left atrium at the bottom, and you can see that interatrial septum bowing quite severely from the right to the left side. So the next thing I did was put some colour Doppler on to see if I could see any blood flow across, and you can't see any. So fortunately the patient already had a central line in by this point, so I put some contrast in. You can see here contrast bubbles filling the right side of the heart, and then in the left side of the heart you can see bubbles appearing, which means they must be going through a hole in the atrial septum. So this patient had a right to left shunt, which I thought explained why they were so unwell. With some change in ventilatory settings, I was able to, you can demonstrate here that the septum now, the pressures have been reversed. The septum's not bowing from the right to the left side, it's now going from left to right. And when I put some contrast in again, here you can see the bubbles in the right side of the heart, but this time there's no bubbles in the left side of the heart. So the shunt has now disappeared because we've been able to reverse the pressures from the right and left side of the heart. Now, most interestingly here, the patient got better in about 15 minutes, and after half an hour was physiologically well, able to be extubated, and they've gone from being gravely unwell, almost peri-arrest, to being better in the space of less than 30 minutes, just based on a focused but not a basic echo.
Okay, I'm going to talk about training programs and training competencies. We've already been asked a question on it already, and so we're going to discuss core competencies in critical care ultrasound. Is it possible to standardize a training program so that colleagues around the globe can learn critical care ultrasound in the critical care setting? One of the key papers that talks about this area is this one, the International Expert Statement on Training Standards for Critical Care Ultrasonography. I want you to note the date. It was from 2010, published in 2011. And essentially a group of 29 experts representing the various bodies of the European Society of Intensive Care Medicine and professional societies came together and decided and discussed, debated what should intensivists know about critical care ultrasonography. So this paper is nearly a decade old now. More recently, there was a systematic review of international training competency and programs published in critical care medicine. And the take-home message from this review was that despite that paper being 10 years old, despite it being supported by over 20 national societies, the majority of countries still lack the formal training program. And even within those countries that did have a training program, what skill set were required remains very, very variable, and there calls for a need to standardize and better define the competencies. And I'm going to illustrate that variability in the following slides. So this is an overview of the various different countries that have got some form of training program for intensivists in critical care ultrasound. And as you can see, and I've made this such that green means there's agreement across the board, or that's included in that program. Yellow, it's a bit uncertain, and red is if there's not that element has not been included. And as you can see across all the various countries shown in the table, there is broad agreement that echo, lung, abdominal, vascular ultrasound should be included in a training program of some form. In terms of how to train them, a course is generally required and recommended. And there needs to be some form of logbook to keep track of that trainers and trainees' progress. But when you delve into it, and the devil is in the detail, this is a breakdown of critical care echocardiography, so cardiac ultrasound. And suddenly variability starts appearing. If you look at the line at the top, the number of scans required by the various different countries to say this is what you need to become competent in critical care echocardiography varies from 30 all the way to 100. There is general agreement that it should involve some form of qualitative assessment. So the binary questions that Ashley has already mentioned, is the left ventricle working, not working, so on and so forth. Quantitative measures, assessment of valves, assessment for the use of color Doppler, the assessment of diastolic dysfunction becomes more variable. Some countries do have them in the program, some countries don't have them in the program. And that variability is replicated in the abdominal side of things. You can see there are various different degrees of green, yellow and red, highlighting there are various differences between the national programs. And this is despite the fact that most of these programs quote and source that initial consensus statement. This is a result of a survey published by Glaser and colleagues back in 2017, and it surveyed national trainers as to why do you think, or what are the barriers to critical care ultrasound in their respective countries. And the top two on the list is the lack of trainers and lack of formally agreed competencies.
So there is several questions on the website, and the first one is when we have to deal with a patient in shock, in septic shock. So the basic echo, it's okay, but it's sometimes difficult without Doppler to have a clear idea of the status, the hemodynamic status of the patient. What is your feeling about this?
Okay, so I have quite strong feelings about this. I think the hemodynamic status, I think you know before you do the echo. So you'll be hypovolemic if you're bleeding or if you're very dehydrated. That should be easy from the history in the examination. If you've not been eating and drinking for a few days, maybe you've had some vomiting and diarrhea, then you're going to need some fluid resuscitation, and that's probably happened very early on. By the time intensive care gets involved, patients nearly always had a couple of litres of fluid, and by that time there's no reason for them to be hypovolemic. The question then is the patient fluid responsive? Which is, again, a bit controversial. We're all fluid responsive in normality. So does being fluid responsive mean that you should have more fluid? Is it beneficial to have your stroke volume increased? We know from studies in sepsis that pretty much all the fluid you give ends up in the tissues quite quickly after you give it. And so I would argue then that echo, it might on the odd occasion detect hypovolemia which you weren't expecting, maybe some internal bleeding if it's a trauma case. But someone who's just shot from sepsis, you will see a hyperdynamic heart probably. A hyperdynamic heart could be a feature of hypovolemia, but could be a feature just of vasodilatation and reduced preload from dilated venous system, low afterload. So the two look the same. Vasodilatation and hypovolemia look very similar with echo.
And is it easy to have a good idea of the contractility Just if you do not take measurement, what is your feeling about this?
Yeah, so you can certainly see whether the ventricle is performing very badly or looks okay. I'm not sure it's especially important to distinguish between an ejection fraction of 40% or 50%. I don't think that's very important. It's more important to know whether it's really bad or okay.
Yes.
Yeah.
Of course, the more you know and the more accurate you can be, the better. But it's not vital to be able to do very detailed, comprehensive scans.
Yes, but it's an easy way to very quickly know that there is something wrong.
Absolutely.
And it prevents to do a mistake concerning catecholamine or fluid expansion.
Yes.
So about training, what do the panel feel should be included in a Pocus training program?
So I think that the Pocus training programs, I think that if you look at all the ones that are out there already, there are elements that everyone agrees on, which is you need some form of theoretical knowledge first, and then that's a given. How you deliver that theoretical knowledge, whether it's an online seminar such as this one, an online library that you log on to, or a face-to-face lecture, that's depending on the individual. It is a practical skill. What that means is that you are going to need some form of direct learning with an expert to learn that skill set. No one goes to a course and immediately comes out an expert. So there is going to be that learning phase that you are practicing, optimizing your image, optimizing your ability to interpret the image, and that is probably best done within the setting of with a mentor by your side, whether it's directly all the time or directly at periodic intervals. That international consensus paper that I referenced to earlier mentions a fixed number of hours of training to gain the skill set. So you're going to, those elements we agree. There needs to be some theoretical knowledge, there seems to be some practical hands-on experience, and whether that is continuous hands-on mentorship, it depends on the resources available, but those two elements I think must be included.
And what about the medical legality of Pocus in case of serious decision, for example, about thrombolytic therapy?
Yeah, so that's an interesting question, and I have myself seen a patient who was thrombolyzed based on an echo, where a dilated right heart was diagnosed. In actual fact, the probe was the wrong way round.
Yes.
And due to the inexperience of the operator, the patient received thrombolysis. Fortunately, they didn't come to any harm from that, so it is a consideration. What's also a consideration, though, is that if there's a tool that is very good at diagnosis and guiding treatment, it would be almost unethical for you not to use it if it was available. So to not use it because you're worried about medical legal aspects, it is, I don't think, a good defence. But it is important that you are trained and competent to do whatever you're doing. And I'm not aware of any legal cases where which have been brought against somebody because of doing an ultrasound examination. But I do believe there has been a legal case where because somebody didn't use ultrasound when perhaps they could have done.
So, do you have recommendation about when we consider the routine hemodynamic monitoring of our patient? So, invasive or non-invasive, and what is the strategy that you recommend?
I think, first of all, the evidence for monitoring is variable, mainly because each unit, each patient is very, very different. We all work in teams. And in our respective units, we practice ultrasound on a daily basis when we're looking after a particular patient. Monitoring without being allied to a treatment plan, treatment strategy, I think is meaningless. So you need to have something that your team is comfortable to use, is comfortable to integrate into the practice and align it with some form of treatment strategies. Now, unfortunately, in the UK, the number of centres that have got point-of-care ultrasound consistently 24 hours a 7 is still something we are working towards, whereas the fact that the use of arterial lines there, as an example, with central venous pressure, central venous catheter access is more established. So from a process systems development point of view, I would argue that use what you've got in your setting. If you've got, or your colleagues are comfortable using the Pico device, what have you, use that well. When you start developing expertise in ultrasound, integrate it into the practice and build your understanding knowledge, not just of yourself, but your entire team to that practice.
An example I sometimes give for this question is, imagine two echo images of two hearts. One of them is small and hyperdynamic. One of them is dilated and functions very poorly. Both of those patients could have the same blood pressure. Both of them could have stroke volume variation. In the terms of the failing heart patient, it would be a false positive because of the heart failure. Both of them could have maybe even the same stroke volume. So I would then say that echo is much more powerful than just a cardiac output monitor that gives you some numbers. If you can actually see what the heart is doing, it's so much more useful, because you get the numbers, but you also get to actually see what's happening.
And it's clear that it's important to assess the response to fluid, and to see what is the response of the heart, for example. And if you want to perform a fluid challenge, so how do you use the echo to test if the response is positive or not?
Yeah, so the simplest way is just to measure what we call the velocity time integral. So you place the pulse wave sample volume in the left ventricular outflow tract, which is very easy to do from your apical forward chamber view. You just tilt the probe a bit anteriorly to reveal the outflow tract. You will get a Doppler tracing. You can trace around that with the machine and it gives you a number. If you want to, you can measure the diameter of the left ventricular outflow tract and get a stroke volume, but that really isn't necessary. It's just more complicated. So if you measure the VTI, you can see how that varies with respiration. And if it's a significant variation, that suggests fluid responsiveness, provided it's not a failing ventricle. You can also do a passive leg raise while you're monitoring the VTI, or you can give a fluid challenge and see if the VTI and the stroke volume increases.
Okay, so what is the future?
Okay, so this is the interesting bit. We thought we'd have a little delve into our crystal ball and see what we think is the way ahead for point-of-care ultrasound. And to me personally, one of the biggest challenges is, can I prove all of this works? Will it make a difference to our patients? Will it improve care, so on and so forth? Or is this just a passing phase? Because everyone is doing it, we're just going to follow the masses and learn point-of-care ultrasound and practice them on our patient. If you look at the literature, and I'm just going to pick up a couple of examples, this paper from last year showed the use of transthoracic echocardiography and mortality in sepsis, analysis of the mimicry database. And there seems to be an association that patients who received a transthoracic echocardiography examinations, so on and so forth, did better in the sepsis cohort. However, for all those studies, there are studies such as this one, which looked at the use of point-of-care ultrasound skills in the emergency department setting and the context of undifferentiated hypotension. So you've already heard how echo can be very, very useful to discern the various different types of shock and so forth. And when applied in a trial such as this one, there was no mortality benefit to the patient. So I suppose the jury is still out there in terms of, does this make a difference? Because it seems so intuitively obvious that we will, because we have improved diagnostic ability, we have improved evaluating ability, we have the ability to monitor our patients better. So the jury is still out whether all of these things will make a difference to our patient.
Yeah, I think you can make a very similar argument for oxygen saturation monitoring or even blood pressure monitoring, can't you? It's very difficult to prove these things are beneficial in a study, but we all know intuitively that they are, because they really change our practice. So one of the really nice things about ultrasound is that the more you learn, the easier it is to learn more. You can think of it like building blocks which you stack on top of each other. So you can learn how to do a basic echo, you can learn your basic lung ultrasound, you can learn your basic abdominal ultrasound. Each bit of ultrasound you learn makes the next bit easier. And once you've mastered it, become proficient with it, you can add more kinds of ultrasound to your arsenal. So you can do things like ultrasound the brain. You can monitor intracranial pressure by measuring optic nerve sheath diameter. You can use transcranial Doppler to look at blood flow within the brain. There's some pictures of that there. So top left, it's very easy to do. You just put your linear probe on top of the globe of the eye with lots and lots of jelly. Don't press too hard. And you can, just a small movements of the probe, you can find the optic nerve and its sheath at the back of the eye, which you can see there as that black anechoic structure, and you can measure that, and that swells and enlarges when there's raised intracranial pressure. We've got some pictures of transcranial Doppler on the other side of the screen there, assessing blood flow within the different cerebral arteries. You can also start to do other more interesting things as well. So this is just a diagram of how various bits of ultrasound, particularly using Doppler signals, change as venous pressures increase. I think we're becoming to understand more and more now that organ perfusion is actually more dependent on venous pressures than it is on arterial pressures, because after all, the blood flow to an organ is very tightly auto-regulated between a wide range of blood pressures, and therefore the pressure gradient for which produces blood flow then becomes dependent on the venous pressures. So we can of course measure central venous pressure directly if we have a central line in, but there's also a number of characteristic ultrasound features, and you can see those in portal vein flow, in renal blood flow, in the IVC. All these things that are on this picture you can integrate together to get a better idea of what venous pressures might be, and therefore what organ perfusion is like. It's also useful for things like more advanced abdominal ultrasound examinations. So say you have a patient with liver disease, it becomes not too much more complicated to be able to start looking at the portal vein, assessing just for starters whether the flow is going towards or away from the liver, looking to see if there's characteristic features of cirrhosis, starting to look at the biliary tree. All these little add-ons you can add into your game to improve your diagnosis.
Okay, so one of the other aspects that evolves alongside our understanding and utilization of ultrasound is technology, the machines that we use. So we're all very familiar with the big ultrasound machine that sits on a cart in the radiology department, but there are now devices out there which are handheld that makes it very, very easy for us to take the ultrasound device to the bedside when we see the patient in the emergency departments or up on the ward setting. So that the hardware side of things, but perhaps more fascinating, is the use or development of the software side of things. So artificial intelligence, machine learning have been in the limelight in the recent years in terms of how to improve medical care, not just within intensive care medicine, but healthcare as a whole. I'm just going to illustrate a couple of examples where it's been used in the ultrasound setting. So this is an apical 5-chamber view of the heart, and as you can see, this is what Ashley was talking about in terms of measuring the velocity time integral VTI. And what the software does is to pick out the aortic outflow tract and put a Doppler cursor over the right thing. The software itself can recognize in terms of how good or how bad the quality of the image is and prompts the user that adjustments might be necessary. Other things, we talked about the IVC, both from questions and the presentation, how we track variability in terms of the size of the IVC, both in terms of during respiratory or just the patient sitting there quietly. And what this software does is to track that variation and allow us to measure and calculate the collapsibility or distensible index for it. We talked about lung ultrasound, we talked about the B lines, which are those vertical lines you see, and you're allowed 2 per rib space, and in this software it picks out those B lines for you. It will then calculate the lung aeration score and present it in a graphical manner so that you can then formulate a treatment plan, treatment strategy. And the fact that it can be recorded, it means that you can record the image, perform an intervention, diuretics, recruitment maneuvers, what have you, and then go back and rescan, and that acts as a record for your treatment. We're all believers in point-of-care ultrasound and we've discussed how best to train colleagues in this skill. But the fact of the matter is that the use of point-of-care ultrasound and ultrasound as a whole is expanding. This is just one of the numerous papers out there highlighting the fact that our medical student colleagues, the doctors of the future, are being exposed to point-of-care ultrasound at a much earlier stage. And so the question that's often asked, and this is just one of the articles that discusses it, will ultrasound scanners replace the stethoscope? One to think about. So to summarize then, we've discussed the fact point-of-care ultrasound and how its use will continue to increase in the field of critical care. The technology will evolve, but we need to best define the competencies and how best to train our colleagues to achieve those competencies.
Thank you, Adrian. Thank you, Ashley. We have plenty of questions, and I'm sorry because I am obliged to make a selection. In atrial fibrillation, it's a very important question. How you use the VTI to measure fluid responsiveness?
You can't. If you have arrhythmias, you can't use it to assess fluid responsiveness.
Okay, it's a limitation.
Yeah.
Okay. And so, Adrian, about the lung, best diagnostic criteria in lung ultrasound for pneumonia?
I think that's a very difficult one because there's different scoring criteria out there. Recently, there's been a publication which talks about the diagnosing pneumonia, allying the clinical pulmonary infection scores and ultrasound abilities. I think what's powerful about ultrasound and how I use it on a day-to-day basis is a diagnosis of exclusion. I look at the patient, I scan the lungs, and I go, okay, do I see mostly a dry lung, which is mostly A lines, or is this a wet lung, B lines? I like to think of one step back. Clinical history and all the other bits are still important. Although we are all believers in ultrasound, it does not replace the clinician. So what's the story behind you performing the scan? Is this a 65-year-old diabetic patient who is a very, very heavy smoker, been unwell for 3 or 4 days with fevers, hot sweats, and is coughing up green sputums? Your pre-test probability is already pushing you down the road of a ultrasound examination. The classical paper by Lichtenstein and colleagues talks about the C profile, and in that webinar earlier we've shown you a very, very obvious example of a consolidated lung. What you see is obviously important. What you don't see is also important. you don't see B lines, you don't see the C profile. All of this you can help use to guide the diagnosis of whether this is pneumonia or not. So from a practical day-to-day basis, that's how I use it. I don't use a scoring system in particular. I look at the line and go, I see this, it's probably this, it's not this, it's not that.
I think another way you can think of that is if you see ultrasound appearances of what may be consolidation or squashed lung, atelectasis, whichever one of those two things it is, that's lung that is pathologic and where gas exchange is not happening or not happening very well. And you know it's one of those two things. It's infection or it's collapsed lung. You can decide between those two from other features. If there's a very large pleural effusion around the lung, then it's clearly going to be squashed. If it looks like there's been an obstruction higher up and then collapsed lung, and you get a raised hemidiaphragm, lots of secretions, you know, that's going to point you in a direction of an obstruction and collapse. You can see whether there's air bronchograms or air bronchograms that are moving, so-called dynamic air bronchograms. So as Adrian said, if you take the pictures in the clinical context and integrate it with fever, other infection markers, then it becomes much easier to work it out.
So do you think that in the future we will have a small portable echo in our pocket in the emergency room, in the operating room and in the ICU?
I don't think it's the future. I think it's already happening. There are lots of manufacturers' devices out there that have developed handheld probes out there to facilitate exactly what you're saying. And obviously we're a biased group of individuals because we're all Pocus practitioners. I think the day is coming, if it's not already here, that ultrasound, be it a handheld device or a more portable device, will replace the stethoscope because it gives so much more information than just the stethoscope alone.
I'll be very, very happy when junior doctors stop walking around with stethoscopes around their necks, instead have ultrasound probes in their pockets.
You talk about training and mostly about training of the resident. But what about the senior? Because it's so important to be able to perform echo now in ICU.
I think that in order for people to want to learn, so be it very junior colleagues or more senior colleagues, there must be an element of value to them. They must first of all believe that this is going to make a difference to them. And I mean, in the UK and across the world, I think there are courses out there that are open to anyone who wants to learn the skill of point-of-care ultrasound. It's not just, these are reserved for doctors and reserved for senior colleagues. However, within your individual department, there are things that you can do to facilitate learning amongst more senior colleagues. Perhaps a small group of them, after hours, scan on the unit, so it's less intimidating for them. But the first step is the need to acknowledge that this is a useful tool and want to learn about it.
Yes. So listen to you, people want to know more and more. So can you recommend any textbook for Pocus?
There are lots and lots of...
Except listen you.
We've got an extensive collection of point-of-care ultrasound books out there. So what I'm going to do is I'm going to put all the resources and references that we've discussed here onto the ESICM blog website. So the website address you can see on the screen at the moment in time. I'll put a list of references by all of you, or the panel here, for people to peruse and take with what you feel.
Thanks a lot. I want to thank you for the clear explanation that you gave us, and also to push us to use more the echo in our ICU and to learn more and to be comfortable with this crucial tool. Thanks a lot.
Thank you. Pleasure.
Thank you.